Hello, everyone. This is Dr. Iftikhar Ali, and today, as a part of our microbiology lecture series, we are going to learn about the infections during pregnancy. That is, the what are the chances of certain infections occurring during pregnancy, and what are the consequences of those infections, and how to prevent that infection from reaching the baby. So this is what this topic basically covers. So let's start. And the first infection and the most important infection is the HIV during pregnancy. Okay, so we all know what the transmission of how the transmission of HIV occurs. It occurs through blood, through semen, and in utero, that is from the mother to the baby. It can also occur through breast milk. Okay, so next is the risk to the fetus. So what is the risk to the fetus, and what consequences can occur in the fetus if the mother has HIV infection? So the first thing is that the baby may not go up to term, so there may be a preterm birth. Second is there may be intrauterine growth restriction, or IUGR, that is the baby doesn't grow to this full size that they are supposed to grow. And then third is vertical transmission. So what do you understand by vertical transmission? Vertical transmission is the process of transmission of an infection from the mother to the fetus, which is still in utero. So this occurs through the umbilical cord or through the placenta. So this process of transmission in the uterus from the mother to the baby is called vertical transmission. Then how is this condition diagnosed? As we know, we have to check for HIV serologies in the mother blood and in the fetal blood also. And then can also do a PCR for HIV RNA. Then what is the treatment? Treatment is triple antiviral therapy. So we have to start the mother on antiretroviral therapy or anti-HIV therapy right during the pregnancy itself, and we have to give zidovudine during labor. So this is another important point, that to cover the risk of the baby acquiring the infection during passage through the birth canal, we put the mother on zidovudine during labor and also during the neonatal period. So why are we putting the mother on zidovudine during neonatal period? As we said in the beginning, that breast milk is another source of infection to the baby. So to prevent that, we have to put the mother on neonatal zidovudine. Okay. Then we coming to USMLE tip. What is the important tip here? We have to understand the role of maternal viral load in determining what the transmission risk is. So coming to our first question, the question is a 28-year-old pregnant woman at 20 weeks of gestation presents for routine prenatal care. She has no significant medical history and reports no symptoms. She has been in a monogamous relationship and is not on any medication. So basically what they are saying here is that she has no risk factors for acquiring HIV infection. Her HIV screening test at her first prenatal visit was positive, and her CD4 count is 650 cells per millimeters, with potential effects of HIV with a HIV viral load of 20,000. So she has no history of opportunistic infections either. So she is concerned about the potential effect of HIV on her pregnancy and her baby. So which of the following is the most appropriate management strategy for the patient to reduce the risk of mother to child transmission of HIV? So here, as we have said before, the last line is the most important. So first we have to read the last line, and then we need to go to the entire question. So the last line here says that which of the following is the most appropriate management strategy for this patient. So this is basically a very simple question, that they are asking what we can do to prevent this infection from going to the baby from the mother. because the mother has already been diagnosed as HIV positive. But the important point here is her viral load, which is quite significant, which is 20,000 copies per ml. She has a considerable viral load, and her CD4 count is also down, which is to 650 cells per millimeter cube. So with both these things that make her a quite severely affected person by HIV, we are going to read the choices for this. Okay, so the choices here are: one is initiate zerovidine monotherapy at 20 weeks. Second is initiate combination antiviral retroviral therapy immediately. Start antiretroviral therapy only in the third trimester. Recommend cesarean delivery, or discontinue antiretroviral therapy after delivery if the infant is not affected. So all of these points almost we have just covered in the previous slide. So the answer becomes very simple, that we have to initiate the combination antiretroviral therapy immediately, and we have to continue it throughout the pregnancy, and then we have to give zidovudine during the birth to prevent infection during passage through the birth canal, and then we have to continue the treatment with antiretroviral therapy during the neonatal period when the mother is breastfeeding the baby. So this is the answer here, and we'll go on to the next slide now, which is about cytomegalovirus infection during pregnancy. So cytomegalovirus, this is another virus that can have some serious effects on the baby. Although there are many viral infections that can occur, but these are some of the most important and very serious infections that can have either cause baby's death in uterus, or sometimes even cause some serious deformities in the baby. Okay, so coming to the transmission of cytomegalovirus, the transmission is through blood, through sexual contact, and through breast milk. Okay, pretty much most of the factors as we saw in HIV. So blood, sexual contact, and breast milk. Then coming to risk to fetus, here the baby may be born with mental retardation, baby may be born with hearing loss, baby may be born with microcephaly. Microcephaly is baby is born with a small head, and hepatosplenomegaly, which is enlarged liver and an enlarged spleen. So those are the possible effects that may be seen in the baby if the mother is infected with CMV. Okay, so diagnosis, again here serology is important. We have to look for the antibodies, CMV, IgM antibody, and IgG antibody. Then we have to do a PCR for viral DNA, and if all of these are positive, then we diagnose the mother as having CMV infection. Treatment, no specific antiviral treatment is available that can be given during pregnancy, but we can definitely give supportive care for mother and the baby if the baby is symptomatic especially. So that is all we can do. And here the USMLE tip, important tip here is that congenital CMV is the most common cause of non-hereditary hearing loss. So anytime you see a question which is mentioning hearing loss in a newborn baby, and you don't see any mention of having any hereditary influence on that, then you have to think of a CMV infection, because that is the most common cause of hearing loss in children. Okay, so coming to our question on this, let us first read the last line of the question, which says, which of the following is the most appropriate next step in management? So they are giving us a different scenario here, and then they are expecting us to choose an answer from the choices. So here the question is, a 27-year-old woman, G1P0 at 22 weeks of gestation, presents for a routine prenatal visit. She reports feeling generally well, but mentions experiencing mild fatigue and occasional low-grade fever over the past few weeks. So she has no specific medical history. On physical examination, there are no remarkable findings. Routine prenatal laboratory tests are done, and they show hemoglobin is okay for a lady. What is White blood cell count is also not elevated. Platelet count is also okay. Urinalysis is normal. Antibody testing reveals IgM and IgG seropositivity for CMV. So she is positive for cytomegalovirus. So what is the most important appropriate step? So based on the previous slide, we are going to look at this question. So administering IV ganciclovir, we said no, there is no role for any antiviral therapy here. Then amniocentesis to treat for the CMV DNA, there is nothing like that. And then what are we going to do? Perform detailed fetal ultrasound. So why are we going to do this? This is basically to rule out any of the effects of CMV that the baby may be having. As we said, the baby may be having microcephaly, so that can be seen on a fetal ultrasound. Okay, so if the baby is having a small head, that can be made out on the fetal ultrasound. Then advised termination of pregnancy, of course, we will not do that. And then repeat serologic testing in 4 weeks. There is no use of doing that because it's going to be still positive and the baby may already be affected by it. So we are not going to do that either. So the answer here is C, which says perform a detailed fetal ultrasound. And why are we going to do that? We are going to do that to check for microcephaly. And now coming to our next infection during pregnancy, we have the hepatitis B infection that may occur even during pregnancy or before pregnancy if the mother is infected with hepatitis B. So in this case, what are we supposed to do? Firstly, the transmission of hepatitis B is through blood and then also sexual intercourse through semen. Then it can be transplacental, or as we just discussed, it can be a vertical transmission, or it can be perinatal. Now, what is perinatal? Perinatal is at the time of birth when the baby is passing through the birth canal and the baby is exposed to the virus. That's called perinatal transmission. So these are the various modes of transmission that can occur. And then what is the risk to the fetus? The baby can, of course, just like the mother, the baby can also be born with chronic hepatitis B infection. And that is possible in almost 90% of the babies who are exposed to this infection. So that is a very high percentage. And this is a chronic infection which mainly affects the liver of babies. And the diagnosis of this is through serological tests. What serological tests are we talking about here? Again, antibody tests like HBsAg, HBeAg, and HBV DNA. So these are the antibody tests. Mostly if you are observing for viral infections, it's mostly the antibody tests that are being done. Then treatment, we give the baby a hepatitis B vaccine and also HBIG, which is the hepatitis B immune globulin, which is given to neonates within 12 hours of birth. So as soon as the baby is born, we vaccinate the baby with hepatitis B vaccine and also give the baby HBIG within 12 hours of the birth. And what is the key USMLE tip in this? We have to know the protocol for managing newborns of HBsAg positive mothers, and which is just as we mentioned above, hepatitis B vaccine and hepatitis B immunoglobulin given within 12 hours of birth. Coming to a question on this topic, a 32-year-old woman so let us first read the question, what it is asking. Which of the following is the most appropriate management strategy to prevent vertical transmission of hepatitis B to the infant? So here the question is quite straightforward. We don't need to waste time on reading through the whole question or through the whole story. The question is itself self-explanatory here, where they are asking which of the following is the best appropriate management strategy to prevent vertical transmission of hepatitis B to the infant. So number one is initiate antiviral therapy. Second one is perform a cesarean delivery to reduce transmission risk. The third is administer hepatitis B immune globulin and hepatitis B vaccine to the infant at birth, and advise the patient to avoid breastfeeding, and then E is monitor the infant for hepatitis B infection at 6 months of age. So what is the strategy to prevent that vertical transmission to the baby? The answer to this is, as we just discussed in the last slide, the C, which is administer hepatitis B immune globulin as well as the hepatitis B vaccine at birth. Okay, so that is what we do. And of course, cesarean delivery is not an option here, as are the other options also are wrong. So mainly we will follow the option C here. Coming to the next infection, which is the varicella infection, which is also known as chickenpox. This infection during pregnancy, what it can cause? Firstly, transmission of this infection is through respiratory droplets, through transplacental, again from the mother to the baby. So these are the two modes of transmission of chickenpox. And the risk to the fetus, what is the risk to the fetus? Limb hypoplasia. What is hypoplasia? The limb size is reduced. That means they have small hands and small feet. So that is the limb hypoplasia. Then there is scarring of the skin, and there is also a possibility of microcephaly, which the baby may be having a small skull. Okay, so these are the risks to the fetus. And then diagnosis, the clinical diagnosis is done firstly based on the features of chickenpox, and then PCR or serology is also done for confirmation. Then treatment, what is the treatment for this? We have varicella immunoglobulin, which is called VZIG, which is for post-exposure prophylaxis. So we give this to the mother to prevent the infection to be spread to the baby. And this is an immunoglobulin which we give before the birth of the baby. And then acyclovir for maternal varicella pneumonia. So we also give a antiviral treatment also here. It does have a role in this. So as acyclovir is the antiviral therapy we give, and this is for the mother we give for the varicella pneumonia. Okay, so treatment is through the VZIG for post-exposure prophylaxis and acyclovir for the mother. Then what is the key USMLE tip here? We have to know the difference between varicella exposure during early and late pregnancy. So there are certain features that can occur during early pregnancy and certain features during late pregnancy. Always remember, the effects of any virus are more prominent and more pronounced if the infection occurs during early pregnancy compared to late pregnancy. So this is an important point that you need to remember. So coming to the question on this, so let us first read the question. Which of the following is the most appropriate next step in management? So we have to read the question here. So 38-year-old woman, G2P1 at 18 weeks of gestation, presents to the clinic with a 2-day history of fever, malaise, and a pruritic vesicular rash that started on her face and spread to her trunk. So and extremity. So these are the classic features of varicella infection or chickenpox infection. So she has no significant past medical history and received childhood immunization in her home country, but does not recall whether she had varicella or was vaccinated against it. So this is a suspicious case of varicella, not confirmed yet. Her 4-year-old child recently had chickenpox. So there is somebody else in the house also who had chickenpox. So there is always a chance of getting it from the child. So what is the next step you are going to do here? So the answer here is administer intravenous acyclovir. So the mother should be given acyclovir, as we read in the previous slide. Maternal infection has to be treated with acyclovir, and then if the baby is born, we have to give varicella, the immune globulin, to the baby. So we don't give this to the mother, we give this to the baby. Mother only receives the acyclovir or the antiviral therapy. Coming to the next one, herpes simplex virus during pregnancy, or HSV during pregnancy. Transmission is through mucocutaneous contact or skin-to-skin contact, example through genital lesions during delivery. So this is also a sexually transmitted disease, and this can also cause infection to spread to the baby when it is passing through the birth canal. And what is the risk to the fetus? The baby may be born with CNS sequelae. What CNS sequelae we are talking about? We are talking about encephalitis, and the baby may also be suffering from seizure disorder. And there may be also disseminated neonatal herpes. So these are herpes are lesions that occur on the skin. So HSV1 mostly involves the face and upper part of the body, and HSV2 mainly involves the genital area. So if the mother is having HSV2 mainly, which is involving the genital area, then the baby may be born with these deformities, which is the baby may be having CNS sequelae, encephalitis, seizures, and the baby may also have disseminated herpes. Diagnosis, clinical evaluation we have to do, and then we have to do a PCR from lesions. So clinical evaluation, the lesions are very prominent and they can be seen on the face as well as the genital area. And we also have to do a PCR from the lesions to confirm the infection of HSV. Treatment is acyclovir during pregnancy, again here to suppress the outbreaks, and we better perform a cesarean delivery because there is a high risk of contracting the lesions during delivery. So we have to do a cesarean delivery. So far in all the other infections, we have read that there was not much role for a cesarean delivery, but in HSV infection, there definitely is a role for cesarean delivery. So the mother has to have a cesarean delivery if she has been diagnosed with the active genital lesions. Okay, so key USMLE tip here is cesarean delivery is indicated to prevent neonatal transmission. So cesarean delivery is the delivery of choice here. So what is the question here? Which of the following is the most appropriate next step in management? Again, here we are given a question, so we have to just see what is the next step in management. A 29-year-old woman at 36 weeks of gestation for a routine prenatal visit. She has come for a routine prenatal visit. She reports a 3-day history of painful genital sores associated with mild fever and dysuria. So dysuria is mainly pain on urination. Then physical examination reveals multiple vesicular lesions on an erythematous base in the vulvar and perineal region. So these are classical lesions of herpes simplex, and we are talking about herpes simplex 2, of course. She has no history of similar lesions in the past, and HSV PCR testing from a lesion swab confirms HSV2 infection. So what is the next step? So how are we going to rule out these choices? So A is administer the valacyclovir, B is administer valacyclovir and recommend vaginal delivery if no active lesion is present, and schedule immediate cesarean delivery, perform fetal scalp sampling to test for HSV DNA, and delay treatment until after delivery. So here the answer is we have to administer antiviral, which is valacyclovir, and we recommend vaginal delivery if there are no active lesions. So remember here, this is kind of a trick question where you are thinking that maybe that is the best option is to do a cesarean delivery, but that is only when there are lesions present in the genital area, especially around the vagina and the vulva. And here he is asking what is the next action. So here, if suppose in the answer is mentioning if the mother has no lesions present on the genital area, then yes, always vaginal delivery is the best choice. But if the mother has lesions, then the delivery of choice is the cesarean delivery. So this is for the herpes simplex virus. Coming to our next one, which is the rubella during pregnancy. This is again a very serious infection and can have very serious consequences on the baby. Transmission of rubella is through respiratory droplets, so through contacts present in the house or in your office, in the surroundings. So it can occur through respiratory droplets. What is the risk to the fetus? It can cause a condition called congenital rubella syndrome, which is also known as CRS. And what are the features of this syndrome? The baby can have hearing loss, the baby can have cataracts, and the baby can have, this is the most serious one, is the congenital heart defects, which is the most important of these heart defects, is the PDA. Okay, so these are the consequences that may occur in the baby through the congenital rubella syndrome. Diagnosis of this condition, this is mainly through, again, serology for rubella IgM antibody and IgG antibody. And treatment is mostly, we can't give any treatment during pregnancy. There is no role for antivirals also, although we can give the baby prevention through vaccination before conception is critical. So every mother has to receive rubella vaccine during before conception of her pregnancy. So prevention via vaccination before conception is very, very critical. So if any mother is planning to become pregnant, then she has to take the rubella vaccine. Okay, so the key USMLE tip here is the clinical rubella, congenital rubella syndrome, which is the CRS, and we have to know the features of this syndrome, which are the hearing loss, cataracts, and congenital heart defects. Question. So which of the following is the most appropriate management for this patient? So basically they are mentioning a patient with features of rubella here. So woman at 12 weeks of gestation presents to her obstetrician for routine prenatal care. She has no significant medical history and is feeling well. During her initial prenatal screening, her rubella immunity status is found to be negative, non-immune. That means she has not been immunized for rubella. She reports that she has never received the rubella vaccine and she is unsure if she had rubella as a child. The patient is concerned about the risk of rubella infection during pregnancy. So which of the following is the most appropriate management for this patient? So what we are going to do here is immediately we have to give the patient a rubella vaccine and advise her to delay conception for at least 4 weeks. Okay, so whenever we hear that a patient has no history of taking the vaccine during childhood or contracting the infection during childhood, then that patient is specifically at risk of getting rubella. So the first option is to get the patient vaccinated, and only then the patient should plan to conceive a baby. And next one is the fifth disease. And fifth disease is also known as the parvovirus B19. And this can occur again during pregnancy, and this can have some serious consequences on the baby too. So transmission of fifth disease or parvovirus B19 is through respiratory droplets and transplacental. And this is the risk to the fetus here is the fetus may be born dead, stillbirth, or the baby may be born bigger than the normal size due to accumulation of excess water, which is a condition known as hydrops fetalis. And this can occur mainly due to severe pneumonia. So the baby can have severe pneumonia leading to hydrops fetalis, or the baby can be born dead if the mother had fifth disease during pregnancy. Diagnosis is again serology, and treatment is supportive management for the fetal anemia. That is, we manage the fetus only, and we can even give an intrauterine transfusion if the anemia for the baby is very severe. Then we can even give a intrauterine blood transfusion. Key USMLE: hydrops fetalis in a non-immune pregnant woman should raise suspicion for parvovirus infection. So we have, if suppose the fetal ultrasound is showing hydrops fetalis, we have to go into the vaccination history of the mother. And if the mother was not immunized for parvovirus B19, then we have to suspect parvovirus infection. So, question on this. Which of the following is the most appropriate next step in management? Again, because most of these pregnancy infections, they have this kind of question where they want the next step in management. So they have given a scenario of a mother of a pregnant woman, and these are the serologic findings here. She's IgM positive, IgG positive, so she is basically positive for parvovirus B19. A detailed fetal ultrasound is performed, which shows mild fetal ascites and a normal anatomic fluid index. So there is some sign of the condition called hydrops fetalis, but it is not a very severe presentation here. So which of the following is the most appropriate next step? So reassure the patient, perform amniocentesis to confirm fetal parvovirus infection. C is refer for fetal blood sampling and consider intrauterine transfusion. So as we just read, this is the best option here. We have to do a blood sampling of the fetus to see what is the level of anemia that the baby is having. And then we have to suggest, if it is very severe, we have to consider intrauterine blood transfusion. So that is the correct answer among the choices. Then last but not the least, this is not the last, there is last but one is toxoplasmosis during pregnancy. So toxoplasma is infection that is acquired through cat feces mostly. So we have to remember the role of cats in toxoplasma infection, and it can also occur due to contaminated food. And of course, what are we talking about? Contamination with cat feces. So that is the reason why food needs to be cooked very well before eating, and any infected food can cause this disease called toxoplasmosis. What is the risk to the fetus? The baby can get chorioretinitis, which is a condition of the eyes, intracranial calcifications, and hydrocephalus, which is accumulation of fluid in the meninges leading to a large head of the baby. Okay, so these are the three risks to the baby: chorioretinitis, intracranial, inside the brain there are some calcifications, and hydrocephalus, accumulation of fluid in the meninges. Diagnosis is serology, mainly toxoplasma IgM and IgG is checked, and we also can do amniotic fluid PCR. And if the infection of toxoplasmosis is found, then the treatment is spiramycin for acute maternal infection. So here toxoplasma is not a virus, it is a bacteria. And the treatment here is spiramycin for acute maternal infection, and pyrimethamine and sulfadiazine if fetal infection confirmed. So this is what is given to the mother. For the mother's infection, we give spiramycin, and for the baby's infection, we give pyrimethamine and sulfadiazine. Key USMLE tip: classic triad. So we have to remember, everyone who is taking the USMLE exam need to remember this triad, which is chorioretinitis, intracranial calcifications, and hydrocephalus. This, if suppose you are seeing it in the question, then this is probably a case of toxoplasmosis. So this is one of the very important infections that you need to remember. Coming to a question on this, again, we have the same thing. Which of the following is the most appropriate next step in management? And if you look at the question scenario, just look at the last part of the question. It's showing toxoplasma positive, IgG, IgM is positive, and detailed fetal ultrasound shows no abnormalities. That means the baby has evidently not got affected by this, but the mother is positive for toxoplasma. So what are we going to do now? So our main aim is now to prevent this infection to spread to the baby and get the baby affected by that. So we have to prevent that right now. So what are we going to do? We are going to confirm if the baby really has that infection or not. Mother is already confirmed, baby has to be confirmed. So what do? We do a amniocentesis to test for toxoplasma in amniotic fluid of the baby. So we have to check for toxoplasma DNA in the amniotic fluid. This process is called amniocentesis. And if suppose it is found, then we are going to do the treatment for the baby, but not without this procedure. which is called the amniocentesis. This is the most important, especially since the baby doesn't seem to be affected by the toxoplasma. Then coming to the last one, which is the syphilis during pregnancy. As we all know, syphilis is another sexually transmitted disease, and it is bacterial infection caused by Treponema pallidum, and the transmission is sexual transmission to the mother and transplacental transmission to the baby. So from the mother to the baby, it can be transmitted through the placenta. So risk to the fetus: the baby can have stillbirth, the baby can have congenital syphilis, which is a condition characterized by these features, which is a baby can have a saddle nose, Hutchinson teeth, and saber shins. So you need to understand these terms and remember these terms, which are associated with syphilis, and specifically the condition of congenital syphilis seen in children. One is the saddle nose. Saddle nose is, as the term suggests, it is like a saddle on a horse or a camel you have seen. The nose is shaped like that. Then Hutchinson teeth, the teeth are smaller than normal babies or normal people. Hutchinson teeth. And saber shins. Saber shins is the shin, which is the lower part of the leg, is very sharp, like a saber. So this is the three features of congenital syphilis. Diagnosis of this condition: we do some tests which are very famous, known as the RPR and the VDRL, and we can confirm this through the treponemal tests, which is the FTA-ABS. And so these are the important tests for this: the non-treponemal test and the treponemal test. So non-treponemal are the rapid plasma reagent, which is the RPR and the VDRL, and confirmatory test is the FTA-ABS. Treatment is through penicillin G, which is given intramuscularly for both maternal and fetal infections. So penicillin G is the treatment of choice for syphilis. So you need to remember that very importantly, and it has to be given for both the mother and the fetus. So as we just said, key USMLE tip is the maternal treatment with penicillin can prevent fetal syphilis if given 16 weeks of gestation, before 16 weeks of gestation. As we said, the earlier the infection is detected, the more chance of harm to the baby. So that is why it's always better to give this injection early in the pregnancy, which is at the 16 weeks of pregnancy. Okay, coming to the question on syphilis, which of the following is the most appropriate next step? Again, here the same question. So the question is basically asking about a patient who's been affected with, who has been diagnosed with syphilis. So let us just read this question. A 27-year-old woman at 32 weeks of gestation presents to routine perinatal care. She has no significant medical history and reports no symptoms. Her first prenatal visit was unremarkable and she has received all recommended screenings. However, on her current visit, her syphilis serology is found to be positive for RPR and treponemal antibody. So this is the condition. She has no history of genital source or other signs of syphilis. She denies any high-risk sexual behavior and is monogamous with a partner who is asymptomatic. The patient is concerned about the implication of the diagnosis of her pregnancy. Which of the following is the most appropriate next step? So as we read just now, the next step is, of course, to administer a single dose of intramuscular penicillin G, which is the treatment of choice for anybody who has been diagnosed with syphilis. So this patient evidently has been diagnosed with syphilis, and we are going to give this patient intramuscular penicillin G to prevent the infection from spreading to the baby. Okay, so that's all we have today of the infections during pregnancy. This is a very important topic, and especially the important infections in this are the HIV, the toxoplasma, the rubella, the hepatitis, and the HSV. So these are the areas that you need to focus on more, and try to especially memorize the USMLE tips that were mentioned in these slides. And until next time, see you.